Hi, this is E. David Crawford, Editor-in-Chief, Grand Rounds in Urology. We are going to have Dr. Laurence Klotz, who is Chief of Urology at Sunnybrook Health Sciences Center and Professor of Surgery at the University of Toronto. He's also Chairman of the World Uro-Oncology Federation. Spend some time with us and give us 3 presentations in our Platinum Lecture Series. Platinum Lectures, as you well know, are lectures that we hear and we think, wow, these are some of the best talks we've heard in the last 6 months. And recently, Dr. Klotz gave one, and I've asked him to come up with a Klotz trilogy, which is going to break this talk down, which covers active surveillance and also micro ultrasound markers and a few other things, into 3 talks, about 10 to 12 minutes each. And we will have these in Grand Rounds in Urology. So Dr. Klotz, thanks so much for taking time from your busy schedule to share with the audience these presentations, and I know they're going to be well received.
David, thanks for the kind introduction. Really, it's a great pleasure to participate in Grand Rounds in Urology. I think it's a tremendous initiative. This is the 3rd talk on active surveillance, and the focus of this talk will be on patient selection, monitoring, and innocuous interventions that are supported by data that are worth considering in patients in whom you're managing low-risk prostate cancer. So a couple of specific subgroups of patients who are candidates where there's controversy. The first is young men. So there's been an idea that keeps popping up that young men have a 30 or the 35-year median life expectancy. Is it really safe to manage these patients conservatively? And perhaps the fact that they're diagnosed at a younger age means that they have more aggressive cancer. We have quite good data now that there's no evidence for low-grade cancer being more aggressive in young patients. And the other side of this coin is that young men have a greater risk of sexual side effects over time with radical treatment. The impact of erectile dysfunction is obviously much greater in a 50-year-old than in a 75-year-old. They're more likely to have low-grade tumors. So prostate cancer tends to become higher grade with age. And young men having a biopsy have a spectrum of cancer that's shifted towards the more favorable end. And therefore, you have a lower likelihood of missing an aggressive cancer in a younger man. And that, as I mentioned in an earlier talk, is really the Achilles heel of the whole active surveillance strategy. This is just one study that showed that age was a significant predictor of the risk of upgrading, or conversely, young age was associated with a lower risk of upgrading. And there's a few studies out there. This is one that I did in collaboration with Adam Feldman's group at Harvard. We pooled our patients under the age of 60, more than 400, with about 12-year follow-up, and on median follow-up was a little over 6 years, but we saw absolutely no difference compared to the older patients in terms of progression rates. The rate of metastasis was virtually 0. And I believe there was 1 patient in the 417 who developed metastatic disease. And I think this is fairly robust support for the idea that at least in the intermediate time frame, these patients are not at increased risk. Now, the caveat, of course, is no one has 30-year follow-up. But so far, there's no evidence that at all of what had been reported in some of the earlier watchful waiting series from Sweden, where patients could be followed for, say, 10 or 15 years and then suddenly have a dramatic increase in prostate cancer mortality. That does happen with the watchful waiting approach, but the active surveillance where you're following the patients, intervening for grade progression, we just haven't seen it at all, nor has any of the prospective series reported that. What about race? There's clearly racial differences in prostate cancer, and I think this reflects genetic predisposition, differences, for example, in the transactivation domain of the androgen receptor. And there's also a number of series that have shown patients that African Americans have a higher rate of upgrading on repeat biopsy. And we now have accumulated data on this. And the question is, is surveillance safe in African Americans and Canadians? And the evidence is, yes, it is safe. Here's one recent study in JAMA. They have higher rates of progression and treatment than Caucasian, but no difference in the rate of metastasis or in mortality, which is what's important. So these patients should be managed with surveillance. They will have a slightly higher increased rate of grade progression for reasons, for potentially multiple reasons, but this does not translate into a difference in metastasis rate as long as they are followed using the now widely accepted principles of active surveillance. You can see these curves show the rate of progression, which is grade progression of definitive treatment. The rate of metastasis and mortality remains exceedingly low in these patients. What about grade group 2? So this is where kind of the rubber meets the road, the real controversy over the limits of surveillance. Our own experience, as I mentioned in an earlier talk, was very mixed with grade group 2 on surveillance in the pre-MRI era. There's no question, though, that many of these are indolent, but Gleason 4 is real cancer with real molecular aberrations and real metastatic potential. So as I mentioned, this is where tissue biomarkers have a role. I think one very robust piece of evidence that many grade group 2 patients are candidates for surveillance comes from the absolutely foundational SPCG4 study from Sweden of radical prostatectomy versus watchful waiting, 29-year follow-up report in New England Journal about a year ago. And the striking thing from this paper, which we all use to support the rationale for radical prostatectomy, is that in the higher grade cancers, 4+3 and higher, there was a massive impact of surgery compared to no treatment with hazard ratios of 5 to 10. But key point, in the Gleason 3+4s, absolutely no benefit of treatment. Now, this was a pre-PSA series. The patients were followed with watchful waiting rather than active surveillance. But there you have it, the foundational paper for the value of radical prostatectomy, and there was no value in the 3+4s. So I'm not arguing for not treating those patients, but I do think the message is clear that many of them do not benefit from surgery. Now, as I mentioned, though, in our own series, Gleason pattern 4 at baseline had a major impact on metastasis-free survival. And even when we looked at the most favorable group, this is called recursive partitioning analysis, where we break the cohort into its small groups of risk factors. So on the left, you see the Gleason 6, where metastasis-free survival is in the 97% range, with as soon as you have elements of pattern 4. And here is PSA less than 10, small volume cancer, 70% metastasis-free survival. So 30% of that group had actuarial metastasis at 15 years. And this is a recent study from Memorial Sloan Kettering of their experience with grade group 2, which I would say is more favorable. It's all about patient selection. So this was more than 200 men with grade group 2 managed with surveillance. If you look at the intervention curve, it's almost exactly the same as it is for the grade group 1 cancers. Around 40 to 50% at 10 years had treatment. No patients with metastatic disease, no patients with prostate cancer mortality. So, and this goes back to 2000. So it includes a lot of patients in the pre-PSA era. So can we identify them, the ones who are candidates? And I would say this is where the biomarkers come in. There's another special group that I just want to emphasize, and that is the group with 5% or less pattern 4. And this group should be managed with surveillance. And the reason is that when there is 5% or less pattern 4, In most cases, this is an artifact of tangential cutting of a Gleason 3 acinus. So I think everyone who's in this field knows that the main difference between a Gleason 3 and a Gleason 4 acinus is the quality of the lumen. Gleason 3 has a normal lumen but lacks the basal cell layer. Gleason 4, the lumen is compromised. And what happens in these surveillance cases is there might be one field where the needle just brushed the lumen, brushed the acinus, missed the lumen. And so on the initial cut, it looks like there's no lumen or a poor lumen. It takes a pathologist to recognize this, go back to the block, take deeper cuts if they're available, and see the lumen to figure this out. And not everyone does that. And the proof of this, there's now 3 or 4 studies that all show the same thing. If you pull out the 5% or less pattern 4 in the on biopsy, the radical prostatectomy shows exactly the same distribution of Gleason score as if it's only 3+3 on the biopsy. So about 2/3 have Gleason 6. Despite seeing a little bit of pattern 4 on the biopsy, it's an artifact. And about 25 or 30% have Gleason 3+4, and the rest have higher grade cancer. The same with Gleason 6 on the biopsy. So I manage these 3 + 5% or less pattern 4 with surveillance as the first treatment of choice, with a little asterisk because you never know. The second point is these patients, it makes a difference if you manage them with the surveillance protocol, particularly the confirmatory and subsequent biopsies. So we went back and looked at the impact of compliance with the protocol on the outcome. And somewhat to our surprise, because there's very few situations in all of oncology where anyone has actually shown that how you follow the patients really makes a difference. Here it makes a difference. So the patients who complied, who had their confirmatory and subsequent biopsies, had improved recurrence-free survival, cause-specific survival, metastasis-free survival, and even a trend to overall survival. So you can't just diagnose the 3+3 and send the patient away. You need to follow them. The final thing I want to discuss is the innocuous interventions. Why? A lot of patients, the type A personality doesn't like the passivity of surveillance. They want to feel they're doing something. Most of these proposed interventions have other health benefits. Often the urologist is the only patient the guy with his grade group 1 prostate cancer is seeing on a regular basis. You can improve diet, lifestyle, and perhaps reduce the risk of biologic progression. So there's 2 groups of interventions. These are the ones I would call the motherhood interventions. These are good for the patient regardless of his prostate cancer. Stop smoking. Smoking cessation is the single most cost-effective intervention in all of medicine. And when you have a patient who's newly diagnosed with prostate cancer, they are very amenable to this message about stopping smoking. Some studies have shown that a specialist who spends 2 minutes counseling the patient to stop smoking has an impact. And you're going to accomplish far more with that than you will with all your efforts to reduce his prostate cancer mortality. Regular exercise. If exercise was a pill, we would all take it. There's at least 8 different ways that exercise has been demonstrated to favorably influence prostate cancer biology, including improved cytokine environment, hormonal function, epigenetic modulation, and so forth, reduced levels of insulin-like growth factor. And finally, dietary modification. Heart healthy is prostate healthy. The thing that everyone knows: avoid obesity, moderate red meat intake, increase fruits and vegetables. So this is important, and you have an opportunity to really make a difference in the patient's health. An issue that comes up is dietary modification. Should you counsel the patient to really strenuously modify their diet? And this meal study, which was just reported in JAMA recently, I think has addressed this. This is probably as good data as we're going to get. It's almost 500 patients, randomized between aggressive intervention towards a vegetarian style diet versus a pamphlet. And what were the findings? No question, the aggressive dietary modification intervention resulted in alteration of the diet, but the impact on the prostate cancer was absent. So no difference in PSA kinetics, in upgrading, or in really anything related to the prostate cancer by modifying the diet. So my belief is, I think there's a general acceptance in medicine that your diet over a lifetime has a major impact on health. But once you're diagnosed in midlife or later with prostate cancer, it probably doesn't make much difference in terms of the outcome of your disease. And then there's three other interventions that I think are worth considering: vitamin D, low-dose statin, and metformin. The evidence for all of these is inferential. There's no randomized trials in the surveillance setting. But boy, the preclinical and epidemiologic data is pretty convincing. First, vitamin D, and this is really for people in northern countries like Canada or northern part of the US, where vitamin D deficiency in the elderly people is ubiquitous. There is one study after another. This is a meta-analysis that shows prostate cancer mortality is closely tied to vitamin D levels. Of course, correlation is not causation, but it costs pennies to take a vitamin D supplement every day. It will reverse the vitamin D deficiency, and I think it's worth doing in these patients if they're not on it already. So this is this is prostate cancer mortality by vitamin D level. You can see a fairly strong association. The next one is statins. This is a huge topic, simply to say that there are many epidemiologic studies that are quite consistent that men on statins have a lower rate of prostate cancer metastasis, all-cause, and prostate cancer-specific mortality. The data is quite consistent. Statins have other health benefits in terms of improving lipid profile and reducing cardiovascular risk. So I encourage essentially all newly diagnosed patients with low-risk prostate cancer to go on a statin. Typically low dose, like Lipitor or Crestor, 10 to 20 milligrams. A few patients will develop myalgia. They should stop it. But for the rest, I think it's a net benefit. And the third group, and probably this is I would say the least well supported by data, but still it's compelling, is metformin. Metformin really looks like a health promotion drug these days. It has two mechanisms of action in prostate cancer. It has a direct action by increasing cellular stress, reduces AMPK activation, and that has an impact on some of the fatty acid synthase and molecular pathways involving mTOR that inhibit prostate cancer progression, and an indirect pathway that involves that's mediated by lower levels of glucose, of insulin-like growth factor, also resulting in decrease in a number of signal transduction pathways. And just to so briefly, this is one recent meta-analysis of more than 1.5 million patients from 30 cohort studies of the effect of metformin in prostate cancer. Very consistent signal showing a decrease in metastasis and prostate cancer mortality in men on metformin compared to placebo. So again, we're talking about men who want to do something. This is an innocuous drug. It does not cause hypoglycemia in normal glycemic patients at all. Most patients have absolutely no side effects, and here you have evidence of benefit. So finally, I'm going to skip this slide because I showed it in one of the earlier talks. Just to conclude the whole story, active surveillance reduces morbidity cost and enhanced the appeal of early detection with prostate cancer screening. Patients do require long-term monitoring. Missed high-grade cancer can be lethal. They need the serial MRIs and biopsy. It requires patient and physician buy-in. I think if the physician is skeptical about the value of surveillance, the patient will pick this up and may end up being overtreated as a result. It's active. It requires real monitoring, annual visits, periodic MRI and biopsy. It's congruent and will benefit by the advances in molecular medicine and artificial intelligence. And you have an opportunity to favorably influence the patient's health with interventions that may both reduce the risk of progression of prostate cancer and improve their overall health. Thank you very much for your attention. I hope you found this worthwhile.